I'll be taking your ophthalmology today. Basically, I want to introduce myself. I am a cataract and refractive surgeon, and I have done my post-graduation and my residency from RML Hospital, New Delhi. And currently, I'm doing my private practice. So basically, I'll be starting with your basics, and we'll be dealing with anatomy first. And in the anatomy, we will be taking each and every structure in detail, right? And later on, we will discuss each and every chapter. So just try to focus on the images which I show you and the mnemonics which I'll give you for each and every topic. So first of all, we'll focus on the anatomy first. So this is our eyeball, right? So if we see the total volume of this eyeball is around 6 ml. Volume of our total, this eyeball is 6 ml. And if we zoom the picture, can you see the anterior-most structure of this eyeball? This anterior-most 1/6 part of your eyeball, which is transparent in structure, is called as cornea. It's called as cornea. What do you mean by transparent? By transparent, we mean that all the light rays which are coming through the cornea, they can pass through this cornea, right? So this anterior 1/6 part of the eyeball is called as cornea, right? And the posterior 5/6 part, this posterior 5/6 part of the remaining eyeball is called as your sclera. It is called as your sclera, right? Can you see in this image, this white part? This white structure is called your sclera, whereas this transparent structure is called as your cornea. Understood? So remember that sclera, this white part, is translucent. It is opaque, right? So light rays cannot pass through it. Whereas cornea, remember, it is transparent structure and light rays can pass through it. And this cornea takes part in refraction of your light. Okay? So are you getting me? Yes or no? Shall we move? No, conjunctiva and sclera are not same. Conjunctiva lies over the sclera, right? Conjunctiva is a transparent structure which is lying over the sclera. It is not the same, right? So coming back to this diagram again, if I show you this cornea and the sclera, can you appreciate the junction of the cornea and the sclera, this part, this red part? This junction of the cornea and your sclera, this junction is called as your limbus. This junction is called as limbus. No need to write down. I'll give you proper notes. Just try to focus in the image only. The junction of the cornea and sclera is called as your limbus. Okay. So another name of this limbus is called as corneoscleral junction. This limbus is also called as corneoscleral junction. Understood? Yes or no? Limbus is clear. What is the location of limbus? It is the junction of your cornea and your sclera. Okay. Understood? Right. Now coming back to the diagram again. So first we will discuss the outermost coat of the eyeball. So the anterior 1/6 part of your eyeball is cornea, whereas the posterior 5/6 part, this part is called your sclera, right? Now coming to the inner structures or the inner layers of the eyeball. Can you appreciate this structure? Can you appreciate this structure? This structure is called your iris. This is your iris, right? And this iris is joined with this structure, which is called your, this one. This is your ciliary body. CB is your ciliary body. So iris is joined with your ciliary body, which indirectly is ciliary body is a continuation of this layer, which is called your, the middle layer of eyeball is called your iris, ciliary body, and your, this one is choroid. So this middle coat of the eyeball is called as choroid. Understood? So middle coat has 3 parts. The anterior most part is your iris, then comes your ciliary body, and then comes your choroid. Remember, in this middle vascular coat, this iris, ciliary body and choroid, they are your vascular layer. They are your vascular layer. These contain blood supply. Okay. This much is clear. Middle vascular coat. Give me a thumbs up if it is clear. The middle vascular coat, iris, ciliary body and choroid constitutes your middle vascular coat of the eyeball. Okay. Now coming to the innermost layer of the eyeball. Innermost layer, if you cut the section, this innermost layer is called your retina. This part. This is called your retina. This retina is also called as your neural coat of the eyeball. This retina is called your neural coat of the eyeball because neuro means it has something to do with your nervous system, right? So this neural coat of eyeball is connected to your brain via optic nerve. This retina is connected to your brain via optic nerve. That is why this retina is called as your neural coat of the eyeball. Understood? Clear? Now, one by one, we will take on each and every structure. So, anterior 1/6 part is your cornea, right? So, we will take on cornea in detail first. Now, write down the heading. We will discuss in detail cornea. So, heading is coats of eyeball. Write down coats of your eyeball. Coats of eyeball. So as we have discussed, there are mainly 3 coats of eyeball. 3 coats are there. The outermost coat is called as outermost coat. Is divided into anterior 1/6 part. Anterior 1/6 part, which is called as your cornea. Right? Remember, this cornea is transparent. Then comes your posterior 5/6 part. Posterior 5/6 part, which is your sclera. And this sclera is opaque. The light rays cannot pass through it. Okay. And the third part, I told you the junction, which is called as your corneoscleral junction. Right? The junction between the cornea and sclera. Tell me what it is called as. Corneoscleral junction. The name is, write down in the message, Limbus. Right? So this is Limbus, which is important for your exam point of view. This Limbus is very, very important. Now, why Limbus is very important for your exam point of view, write down. This Limbus contains stem cells. It contains stem cells. That is why it becomes important for your exam. Now, write down important question. The universal marker of stem cells, is CD34. Here comes your exception, except limbal stem cells. And the marker of the limbal stem cell, write down. The marker of limbal stem cell is ABCG2. This is an important question which is commonly asked in your exam. Marker of limbal stem cell is called as ABCG2. Right? Okay. So this is about this is all about your limbus. Then comes your write down layers of cornea. Layers of cornea. So first we will discuss cornea in detail. Cornea, as I told you, this is the anterior transparent 1/6 part of your eyeball. Now, layers of eyeball. There are total 6 layers of eyeball. And the mnemonic for layers of eyeball, write down, is A, B, C, D, E, where there are two Ds. Where there are two Ds in the layers of cornea. Total, there are 6 layers of cornea. Write down the first one and the outermost layer of the eyeball or the cornea. Outermost layer of the cornea is called as epithelium. So A stands for anteriormost epithelium. So outermost layer of the cornea is epithelium. Now question which is asked in exam is, write down, this epithelium is made up of, non-keratinized, stratified squamous epithelium, right? So this outermost epithelium or the outermost layer of the cornea is made up of which epithelium? It is made up of non-keratinized stratified squamous epithelium. Clear? Now, important point about epithelium is that it is a germinative layer. It is a germinative layer. What do you mean by germinative layer? It means that this layer epithelium can regenerate. It can regenerate. And the complete turnover or the healing process of the epithelium usually takes around 6 to 8 days. In 6 to 8 days, complete turnover or complete healing of epithelium of the cornea takes place around 6 to 8 days. Now, what does it mean? It can regenerate. Means, suppose a foreign body falls in your left eye while you are driving on a bike. Suppose a small foreign body falls on your eye, inside your eye, and this foreign body is lodged in your epithelium of the cornea. It has damaged your epithelium of the cornea. So what we do, we remove the foreign body and we no need to do anything. The epithelium will heal on its own, and usually it takes how much time to heal? 6 to 8 days, around 1 week for healing, right? So this means that this epithelium is a germinative layer and it can regenerate. So important question, write down. Corneal abrasion. Corneal abrasion. Abrasion means the superficial corneal wound or superficial corneal abrasion. They does not cause loss of vision. LOV means loss of vision. So you need to just wait and watch. It will heal on its own because epithelium is. This much is clear or not? Message box, please. Epithelium of cornea is clear. Okay. So we have discussed the outermost layer. Mnemonic is A, B, C, D, E. So next is B, right? So second layer starts from B, which is called as Bowman's layer. It is called as Bowman's layer, right? Important point, write down about this Bowman's layer, that it does not regenerate. It does not regenerate. Next important point, it heals by scarring, right? Now, suppose that foreign body, when you were driving on a bike and the foreign body falls in your left eye, suppose the foreign body has entered in your Bowman's layer. The lesion is a deeper. Now, this Bowman's layer will not regenerate and it will heal by scarring. Now, this scarring will lead to, leads to permanent loss of vision. Write down. This leads to permanent loss of vision. LOV is permanent loss of vision. Now, important question which is asked in Bowman's layer, write down. Most common collagen in Bowman's membrane. BM is Bowman's membrane or Bowman's layer. The most common collagen is type 1 collagen. Most common collagen present in Bowman's layer is type 1 collagen. Next important question, write down. The most common ground substance. The most common ground substance of Bowman's layer, and the answer is keratin sulfate. Answer is keratin sulfate. It is made up of keratin sulfate, right? So this is all about your second layer, which is Bowman's layer. Now going back to the mnemonic again, the third layer is ABC. C stands for corneal stroma. C stands for corneal stroma. So the third layer is called as stroma. And this stroma, important point is that this constitutes 90% of your thickness. 90% of your corneal thickness is constituted by your corneal stroma. Clear? So if they ask you which is the thickest layer of the cornea, answer will be your stroma. Stroma is the thickest layer. And again, this stroma is made up of type 1 collagen. Type 1 collagen. And the most common ground substance, again, most common ground substance is again keratin sulfate. It is keratin sulfate. Clear? So this is about your third layer, which is called as corneal stroma. Now coming back to again A, B, C, D. So I told you there are 2 Ds, right? So the first D is now Dua's layer. Dua's layer. Now this Dua's layer is recently identified corneal layer. This layer is recently identified. And this is your toughest layer. It is your toughest corneal layer. Dua's layer is your toughest corneal layer. Clear? So this is all the 2 points you have to remember. Ground substance means that the stroma is made up of, right? So stroma main constituent is keratin sulfate. So fourth layer is Dua's layer, and the fifth layer again the D's. I told you there are 2 D's, right? So second D is called as Descemet's membrane. Descemet's membrane. Second D is Descemet's membrane. Now important question which is asked in Descemet's membrane, write down. This layer, it can regenerate. It can also regenerate like which layer of cornea, which we have studied recently, which was also regenerating. Write me in the chat box. Which other layer can also regenerate in cornea? Epithelium, right? So similarly, like epithelium can regenerate, Descemet's membrane can also regenerate, right? Now, next or the innermost layer of the cornea is called as A, B, C, D, E. So E stands for endothelium. Write down. E stands for endothelium. Important question, write down in endothelium that this endothelium is most metabolically active layer. Metabolically, this is the most metabolically active layer. Clear? Next important point, write down that this endothelium act as a barrier. It acts as a barrier to aqueous humor. It acts as a barrier to aqueous humor to enter the cornea. To enter the cornea. What does it mean now? What does it mean? This much is done. Have you written it? Endothelium. Now going back to the diagram again. Now, can you see this diagram? Picture? Yeah. Okay. So this is your cornea, right? So can you see behind the cornea there is a space? This space. This space is called your aqueous humor, right? So behind the cornea and in front of your iris, there is a potential space which is called as anterior chamber, right? So this is your anterior chamber. Now if I draw the diagram, this is your, suppose, cornea. This is your iris, right? And this is your normal biconvex lens. This is your cornea. And this is your iris. So behind the cornea and in front of the lens, this space is called your AC. AC means aqueous humor, right? This aqueous humor, this AC is called as anterior chamber. This is called as your anterior chamber. This anterior chamber is filled with your aqueous humor. It is a liquid which is present in your anterior chamber, right? So understood the anatomical location of the anterior chamber. It is present behind the endothelium of the cornea and in front of the iris. So behind the cornea and in front of iris, this is iris. There is a space which is called as anterior chamber, which is filled with your, which liquid? Aqueous humor. Understood? Yes or no? Yes or no in the chat box? If it is clear, anterior chamber. Anterior chamber is filled with which liquid? Aqueous humor. It is present behind the cornea and in front of the iris. Clear? Now, can you appreciate a potential space is there behind the iris and this lens, biconvex lens? Right? Can you appreciate this potential space is there behind the iris and the lens? This potential space behind the iris and the lens is called your, it is called as posterior chamber. It is called as posterior chamber, and again this posterior chamber is filled with your, which liquid? Aqueous humor. Aqueous humor, right? Just try to understand in the image. I'll give you the notes, so no need to write down right now. Just understand the anatomy, right? So what is the location of anterior chamber? Anterior chamber is present behind the cornea and in front of iris, whereas posterior chamber is present behind the iris and in front of the lens. This potential space is your posterior chamber. Both anterior chamber as well as your posterior chamber, both contains liquid which is called as aqueous humor. Understood? Both anterior chamber as well as your posterior chamber, they contain aqueous humor. Yes or no? Is it clear? Or should I repeat? Is this clear? Yes or no in the chat box? Clear. Okay. Okay, great. So now coming back to endothelium right now. Coming back to the endothelium, as I told you, this is the metabolically most active layer and it acts as a barrier to aqueous humor, which prevents the entry of the aqueous humor inside the cornea, right? So it acts as a barrier. Suppose if there is any injury to your endothelium of the cornea, what will happen? Automatically, the liquid which is aqueous humor in the anterior chamber, it will try to enter inside the inner layers of the cornea, right? Now, what will happen if the fluid will enter inside the what will happen if the fluid will enter inside the cornea? The transparency of the cornea will be gone, right? The transparency of the cornea will be gone and it will lead to corneal opacity. It will lead to corneal opacity, right? So if your endothelium gets damaged, what will happen? The aqueous humor will enter inside the innermost layer of the cornea and it will lead to your corneal opacity. Now, suppose this is our cornea. Someone asked me posterior chamber once again, right? So this is your cornea, suppose. Let us discuss again. Cornea. This is your iris. This is our lens. This is our biconvex lens. Now, can you appreciate a potential space is there? This blue color, potential space is present behind the iris and in your front of your lens. This potential space, blue color, is called as posterior chamber. PC means posterior chamber. And this space behind the cornea and in front of iris, this is called as anterior chamber, right? Remember, the posterior chamber as well as anterior chamber both contains aqueous humor. Both contains aqueous humor. This much is clear. AC and PC both contains aqueous humor. So anatomically that is clear. Yes or no? Okay. Great. Now write down the question which is asked in your exam. They will ask you endothelial. They will ask you endothelial cell count. Write down endothelial cell count. What is the normal endothelial cell count? So normal endothelial cell count, write down, it is somewhere between 2500 to 3000 cells per square millimeter. This is the normal endothelial cell count in a normal individual, right? In a young patient, the normal endothelial cell count is 2500 to 3000 cells per square millimeter. Now, suppose if this endothelial cell count is less than 500 cells, if it gets less than 500 cells, then what will happen? What will happen? Automatically, when the endothelial cell count is decreases, the transparency of the cornea will be hampered, right? And the cornea will become hazy. Cornea will become hazy. What will happen? The metabolic activity of the endothelium will decrease. Remember, endothelium was metabolically most active layer, right? So when the endothelial cell count decreases, metabolically, the metabolic activity of the cornea automatically decreases, and that condition is called as corneal decompensation. That condition is called as corneal decompensation. This is an important question. They will ask you in the exam, what is the endothelial cell count in a decompensated cornea? Answer will be this one. Answer will be less than 500 cells. Less than 500 cells per millimeter square. Clear? Decompensated cornea is clear? Yes or no? Yes or no in the chat box. Decompensated cornea means when the endothelial cell count is less than 500 cells, then it is called as decompensated cornea. Right? Now, by the help of which instrument you measure the endothelial cell count? Write down question. How to measure cell count? So there is an instrument to measure the endothelial cell count, and the answer is specular microscopy. Specular microscopy. So with the help of specular microscopy, we measure the endothelial cell count. Okay. So whenever try to understand what we do, what is the clinical importance of this specular microscopy. So have you heard of cornea transplantation. In the advertisement also you have heard of keratoplasty or cornea transplantation. Whenever someone is donating the cornea and we are recruiting that cornea, fresh cornea, then we are transplanting those cornea in the needy individual or some patients with corneal ulcer, then what will happen? We check the clarity of the cornea with the help of microscope, which is called as specular microscope, this one. So what we see in the specular microscope, we check the endothelial cell count. In normal individual, the endothelial cell count is 2500 to 3000 cells per millimeter square, right? So whenever the endothelial cell count is less than 2500, that cornea becomes hazy. The cornea becomes hazy. Understood? So this is the clinical importance of your endothelial cell count and your specular microscopy. Yes or no? Is it clear? In the chat box, give me a ping if it is clear. Shall we move on? Okay, good. So this is all about your endothelial cell count. Now, if they ask you next question, write down, important question. What is the blood supply? What is the blood supply of cornea? What is the blood supply of cornea? Then answer will be that this is an avascular structure. This is an avascular structure. There is no blood supply of cornea, right? Now, before coming to this class, I was in OPD and I was removing a foreign body on the cornea, right? With the help of 26 gauge needle, I was removing the foreign body, corneal foreign body, and by accidentally that needle pricked me, right? That needle pricked me on my finger and I did nothing, right? Why? Why I did nothing? No precaution I took. Why? Because cornea has no blood supply. It is avascular structure. Okay. Right. Now, next question, if they ask you, what is the nerve supply of cornea? What is the nerve supply of cornea? Now, to remember the nerve supply of the cornea, you have to remember the mnemonic, which is TON. TON is phonetically similar to dawn, right? So, remember the mnemonic TON, where T stands for trigeminal nerve, which gives off branch to ophthalmic nerve, nasociliary nerve. So this is your mnemonic for your nerve supply of cornea. Remember the mnemonic TON, where T stands for trigeminal, gives off branch to ophthalmic, which further gives off branch to nasociliary nerve. Clear? Okay. Now, next important question, write down. In the exam, they will ask you, what are the causes of reduced corneal sensations? What are the causes of reduced corneal sensations? Right? So how do you check the corneal sensations? In your OPD, how you check your corneal sensations? With the help of cotton wisp. We touch the tip of the cotton on the tip of the cornea and we check the blink reflex. What we check? We check the blink reflex, right? Now they will ask you, what are the causes of reduced corneal sensation? Important question. Write down the mnemonic for reduced corneal sensation. HDL, ACTS, where H stands for herpes keratitis, Keratitis means, kerato means in ophthalmology, wherever you study kerato, kerato means cornea. Kerato means cornea, right? And itis means inflammation, right? So inflammation of cornea is called as keratitis. So H stands for herpetic keratitis. First differential diagnosis is herpetic keratitis. D stands for diabetes. L stands for leprosy. L stands for leprosy. And A stands for your acoustic neuroma. Acoustic neuroma. C stands for contact lens wearer. C stands for contact lens wearer. So all of you who are wearing contact lenses for extended period of hours, more than 8 hours a day, remember, all of you are going to have decreased corneal sensations in long run, right? So it is not advisable to wear contact lenses for extended period of time. Understood? So this is the complication of contact lenses. They decreases your corneal sensations. Now coming to next, T stands for overuse of, T for topical drugs. Overuse of topical drugs like which drugs? NSAIDs and beta blocker. NSAIDs and beta blockers like timolol, right? Timolol. Now S stands for surgical trauma. S stands for surgical trauma. So this is the mnemonic for decreased, reduced corneal sensation. HDL ACTS. Clear? Steroids also cause glaucoma. Yes, steroid-induced glaucoma is there. We will discuss later on in glaucoma. There is steroid-induced glaucoma also. This much is clear. Reduced corneal sensations. Yes or no? Ping me in the message box if it is clear. Shall we move on? Reduced corneal sensations. Okay, great. Now coming to the next question. What are the causes? Write down. Next question is causes of enlarged or prominent, enlarged prominent corneal nerves. So there are certain pathological conditions in which the corneal nerves becomes more prominent or more enlarged. So they will ask you what are the causes or differential diagnosis of enlarged corneal nerves. To remember the causes, write down the mnemonic is link. The mnemonic for enlarged corneal nerve is link, where L stands for leprosy, I for idiopathic, where N stands for neurofibromatosis. Neurofibromatosis. K stands for keratoconus. Kerato means, again I told you, kerato means cornea, right? Conus means cone shape. So cone shaped cornea is called as keratoconus, and we will discuss it in cornea. What is keratoconus? So there I'll ask you about keratoconus. What are the causes of enlarged prominent corneal nerves? Differential diagnosis is, mnemonic is link. Link is the mnemonic. Clear? Next, write down. In the cornea itself, write down what is the horizontal diameter. What is the horizontal diameter of cornea? Normal. This is the normal condition which we are discussing. Normal horizontal diameter of cornea, write down, it is 11.7 millimeter. You have to remember the figure also. 11.7 7 millimeter is the normal horizontal diameter of the cornea. Now, if they ask you normal horizontal diameter of cornea at the time of birth, then answer will be 10 millimeters. This is in adults. This 11.7 is in adults. At the time of birth, it is 10 millimeters. Now, there is a condition which is called as microcornea. Micro means small, right? So, small cornea, smaller than normal. In microcornea, remember, the size of the cornea is less than, horizontal diameter is less than 10 millimeters. Then you will coin the term as microcornea. Important question which they ask you, this microcornea is associated with which syndrome? Then answer is, it is associated with congenital rubella syndrome. It is associated with congenital rubella syndrome. Microcornea is associated with congenital rubella syndrome. Clear? Now, if there is microcornea, then definitely there has to be macrocornea also, right? Macro means large corneas, large corneas. So what do you mean by macrocornea? Write down. If the horizontal diameter of cornea is more than 12 millimeters at the time of birth, then you call it as macrocornea. And if it is more than 13 millimeters in adults, if it is more than 13 millimeters in adults, then also you will say it as macrocornea. Then also it is macrocornea. This macrocornea, write down important question. This macrocornea is associated with which two syndrome? First one is Marfan syndrome. Macrocornea is associated with Marfan syndrome. And the second syndrome is Down syndrome. Right? So, macrocornea is associated with Marfan syndrome and Down syndrome, whereas microcornea is associated with congenital rubella syndrome. Clear? Right. Now, there is another term which is called as ophthalmos. Ophthalmos. What do you mean by buff? Phonetically, buff sounds similar to bullseye, right? Bullseye. So, means ophthalmos means bullseye, larger corneas, right? So, if the corneal diameter is more than 13 millimeter, write down. In ophthalmos, there is more than 13 millimeter corneal diameter. Then what is the difference between macrocornea and ophthalmos if the diameter is more than 13 millimeter? The condition in ophthalmos is that you will coin the term as ophthalmos only and only if it is associated with raised intraocular pressure. IOP is, write down, IOP is intraocular pressure. So what is IOP? We will discuss in glaucoma. Normal IOP is 11 to 21 millimeters of mercury. Normal intraocular pressure in human is 11 to 21 millimeters of mercury. This much is clear? Yes or no? Ophthalmos. Ophthalmos, buff means bullseye. Yes or no in the chat box if it is clear? Okay, great. So this is all about your ophthalmos. Now write down, what is the normal refractive index of cornea? This figure also you have to remember the number. Refractive index of cornea is 1.376. Important question. And if they ask you what is the refractive power of cornea? Normal refractive power of cornea somewhere around 43 diopters is the refractive power of cornea. If they ask you of whole eyeball, power of whole eyeball, it is around 60 diopters. Out of this 60 diopters, 43 diopters is constituted by cornea alone, right? Okay. Now, next term is, write down, next term is new term, pachymetry. Pachymetry. Any idea what is pachymetry? Pachymetry means, write down, it is a technique to measure, this pachymetry measures your corneal thickness. If you want to measure the thickness of your cornea, then that can be done with the help of pachymetry. Pachymetry. Clear? Okay. Now, as I told you that cornea is avascular structure, then can you tell me how the cornea is getting nutrition from? Cornea is getting nutrition from, next heading, write down, corneal nutrition. If cornea is avascular, from where cornea is getting nutrition? Someone has answered aqueous humor. That is the correct answer. Okay. So write down in corneal nutrition, write down cornea derives nutrition from glucose and oxygen. Right? Mainly from glucose and oxygen. This glucose, write down, this glucose 90% is coming from aqueous humor. 90% is coming from aqueous humor, 10% is coming from limbal capillaries, right? And this oxygen is directly coming from air. Oxygen is coming directly from air. Now, can you tell me what is the importance of limbus? We have discussed limbus. So, limbus contains which type of cells? Limbus contains which type of cells? Answer me. Limbus contains stem cells. That is why it becomes important, right? Next, write down, after corneal nutrition, next terminology is keratometry. Next terminology is keratometry. I'll show you the corneal images. If you see the structure of the cornea, see, these are the 6 layers of the cornea as we have discussed. The mnemonic was A, B, C, D, E, where outermost was anterior epithelium, right? Then comes your Bowman's layer, second layer. Then comes your stroma, right? So as I told you, stroma constitutes 90% of the corneal thickness, right? So this is your thickest corneal layer. Then after stroma comes your recently diagnosed layer or the recently identified layer, which is called as Dua's layer. Now this Dua's layer is named after an Indian scientist or Indian doctor, which is Indian doctor, Dr. Harminder Dua. He's a alumni of Maulana Azad Medical College and currently is practicing in London, UK. So this Dua's layer is named after Dr. Harminder Dua, and this is recently identified corneal layer, which is present. They will ask you the location of Dua's layer. This Dua's layer is present in between 2 layers, right? Stroma and your Descemet's membrane. Stroma and your Descemet's membrane. Clear this much? This diagram is clear? After Dua's layer comes your Descemet's membrane. What was the important question in Descemet's membrane? Descemet's membrane can also regenerate, right? Like epithelium, Descemet's membrane can also degenerate. And the innermost layer was endothelium, which was the most metabolically active layer. Can you tell me which liquid is present in contact with the endothelium? Behind the cornea, which liquid is present, which is touching the endothelium of the cornea? Aqueous humor, right? Damage, what will happen? aqueous humor to seep inside the inner layers of the cornea, and it will lead to corneal opacity. It will lead to corneal opacity, right? Okay. Now, coming back to the theory, we were discussing keratometry. The new terminology has come now. Keratometry. Write down what is keratometry. It measures. Keratometry is it measures radius of curvature. It measures radius of curvature of anterior corneal surface. It measures radius of curvature of anterior corneal surface. Important point is that you have to remember anterior here. It does not measure your posterior corneal surface, right? So if you take a section of the cornea, this, suppose this is your cornea, right? Now this cornea has two surfaces, anterior corneal surface and your posterior corneal surface, right? Now this keratometry, remember, this takes into account only and only anterior corneal surface and not the posterior corneal surface. Clear? Okay. So this is the technique of measuring the radius of curvature of anterior corneal surface, which is called as keratometry. Kerato again, kerato means cornea, right? Okay. Now next technique is called as corneal topography. Corneal topography, right? What is corneal topography? Topo means surface, right? So something has to do with the surface of the cornea. Something has to do with the surface of the cornea. Write down. This is the study of topography, is the study of its shape of corneal surface. Clear? Okay. Next terminology, write down. Next terminology is corneal esthesiometer. Corneal esthesiometer. What is corneal esthesiometer? Write down. This is an instrument which measures corneal sensations. It is an instrument by which we measure the corneal sensations. These corneal sensations are also measured, as I told you in our OPD, how we measure corneal sensation with the help of cotton wisp, and we check the corneal blink reflex. So they are also measured by blink reflex. Blink reflex. Now this corneal blink reflex has two pathways. It has two pathways. Afferent pathway, write down. Afferent pathway and your efferent pathway. Important question is that this afferent pathway is regulated by or controlled by trigeminal nerve, whereas efferent pathway is controlled by facial nerve. Efferent pathway of your blink reflex is controlled by facial nerve, and afferent pathway of the corneal blink reflex is controlled by your trigeminal nerve. Clear? Okay. Now suppose a patient comes to your OPD and he complains to you of some foreign body sensation, and you check the patient on your slit lamp and you see some corneal defect or epi defect or some foreign body is present. So how you diagnose the corneal foreign body? Write down. Write down. Next topic is dyes. Dyes which are used for corneal staining. Dye is used for corneal staining. So if you suspect that there is any epithelial defect on the cornea due to any keratitis, corneal infections, corneal ulcers, or due to some foreign body, then you have to stain the cornea with certain dyes. And the most commonly used dye in our OPD, the name is right down, fluorescein dye. Fluorescein dye is the most commonly used in our OPD dye in routine basis. Right? What is the normal color of this fluorescein dye? It is an orange color dye. So orange color impregnated drip, this strips come, which these strips come which are orange in color, and we, with the help of this strip, we touch this strip on the tip of the cornea and we stain the cornea, right? So write down the uses of fluorescein dye now. These are used to stain. Fluorescein dye is used to stain the denuded epithelium. Denuded epithelium, also called as epithelial defect. Epithelial defect in corneal ulcers. In corneal ulcers. Here, second dye name is rose Bengal dye. Rose Bengal dye. This rose Bengal dye is not very commonly used in our OPD. The reason being that it causes stinging sensation to the patient, leading to patient discomfort, right? That is why it is not very commonly used, and the commonly used one is fluorescein dye. Write down about rose Bengal dye. This is used to stain. Rose Bengal dye is used to stain devitalized tissue. Devitalized tissue. So someone had asked, what is denuded epithelium? Denuded epithelium means epithelial defect in the normal epithelium of the cornea. Rose Bengal dye is used to stain devitalized tissues. Again, we use these dye to stain the cornea in corneal ulcers, right? Now, important question in rose Bengal dye, write down why it is not very commonly used in OPD. Because it causes stinging sensations leading to patient discomfort. It causes foreign body stinging sensations in the eye. That is why we don't use it very frequently. Okay. So this is all about your rose Bengal dye. Dyes we have discussed, fluorescein dye and rose Bengal dye. Now coming back to the so we have this cornea, 1/6 part. Now we will take sclera. The outermost posterior 5/6 part is called as sclera, right? So write down in sclera heading sclera. Next heading is sclera. The important question which it is not uniform. Its thickness varies. Its thickness varies, right? So the thickness of the sclera is not uniform. Its thickness varies. Now, question which is asked is, write down, important question in sclera. They will ask you, what is the location of thinnest sclera? They will ask you the location of thinnest part of the sclera. Then answer will be, answer is posterior to insertion of rectus muscles. Now suppose this is our globe, right? Suppose this is our eyeball and this is our optic nerve. This is our cornea, right? The innermost optic nerve. Yeah. Now suppose this is your sclera. The outermost layer is sclera, white part, which is opaque. From behind, these muscles are inserting into the sclera, right? These muscles are called as your rectus muscles, right? These are called as rectus muscles. So if they ask you what is the location of thinnest part of the sclera, answer will be it is just posterior to the insertion of rectus muscle. Okay, so just posterior. So you have to remember this posterior word. They will ask you anterior, posterior. So it is not anterior to insertion of recti. It is just posterior to the insertion of recti muscle somewhere here. This is the location of your thinnest part of the sclera. This much is clear? Yes or no in the message box, chat box right now. Thinnest sclera. Yes. So you have to remember that it is located posterior to the insertion of rectus muscle. Now, if they ask you what is the location of thickest sclera, write down. Thickest part of the sclera. Any idea which is the thickest sclera? Location of thickest sclera? Any idea in the message? Location of thickest part of the sclera? Then answer will be, if they ask you, it is around the optic nerve. Can you see this is optic nerve? So this optic nerve is arising from this part of the sclera. So around the optic nerve, you will get thickest sclera is present around the optic nerve. ON is optic nerve. Optic nerve. So this is all about your sclera. This is all about your sclera. Okay. Next, write down. So we have discussed cornea, we have discussed the sclera. So we have, in totality, we have discussed the outermost part of the eyeball, right? Now we will discuss the middle layer of the eyeball. And you all know the middle vascular layer is called as uvea. It is called as uvea. This uvea is, write down, this is the middle vascular layer. Unlike cornea, right, which is avascular, uvea is vascular layer. And this uvea is divided into three parts. The most anterior part we have seen in the picture, that is called as iris. Then comes your ciliary body, the middle part. And the posterior part is called as choroid. Posterior part is called as choroid. Clear? Now first we will take on iris. First heading is iris. Now suppose this is your iris, this is your pupil, and this is your iris, right? So this iris is made up of two muscles. So first we will discuss the muscles of the iris. First set of muscle is called as, iris is made up of sphincter pupillae. Iris is made up of sphincter pupillae, right? This sphincter pupillae, write down the function of sphincter pupillae. It causes constriction of pupil. It causes constriction of pupil, right? So sphincter pupillae muscle causes constriction of the pupil, and that constriction of pupil is called as meiosis. Meiosis means constriction of pupil. Clear? So that constriction of the meiosis is controlled by which group of muscle of the iris? Sphincter pupillae muscle. Sphincter pupillae muscle. Sphincter pupillae causes meiosis. Meiosis means small pupil, constricted pupil. Now the second group of muscle is called as dilator pupillae muscle. Dilator. So as the name suggests, can you see? It is dilating the pupil. So this is very easy. You can understand by the name itself. It is dilating the pupil. So write down the function of dilator pupillae muscle. Very easy. It causes dilatation of pupil. Right? This dilatation of pupil is called as, the term is called as mydriasis. Important. Mydriasis. Is controlled by dilator pupillae muscle, and the term is called as mydriasis. The term is called as mydriasis. The term is called as mydriasis. Am I audible now? Am I audible now? Okay. So that is called as mydriasis. Now write down the nerve supply of meiosis. Write down. We will discuss about meiosis. Meiosis means constricted pupil, right? Meiosis of the pupil is regulated by parasympathetic nervous system. Remember, the parasympathetic nervous system will decrease your tone. It will decrease your meiosis. So meiosis, remember, the size of the pupil is decreasing. So it is regulated by parasympathetic nervous system, which in turn is regulated by oculomotor cranial nerve. Oculomotor nerve. That is important. Short ciliary nerve. Clear? So if they ask you in the question that meiosis is regulated by which nerve, answer will be short ciliary nerve. And it is very easy to remember that because in meiosis the size is getting small, so that is why it is regulated by which nerve? Short ciliary nerve. Clear? Similarly, mydriasis, talking about mydriasis. Mydriasis was the big size pupil, the dilated pupil is mydriasis, right? So it is regulated by which nervous system? Sympathetic nervous system. Mydriasis is regulated by sympathetic nervous system, which in turn is regulated by long ciliary nerve. It is regulated by long ciliary nerve. Clear? So this is all about your iris long ciliary nerve and short ciliary nerve, mydriasis and meiosis you have to remember, right? Now talking about the root of the iris, important topic, root of the iris. Write down. This root of the iris, remember, important point about root of iris is, write down, that this is your thinnest part of iris. Root of the iris is the thinnest part of the iris. So obviously when it is the thinnest part of the iris, it is very vulnerable to get damaged by the help of with the trauma. Suppose a patient has gone under a blunt trauma or there is any injury to the eyeball with the help of any fist, right? Due to any fist. So which is the most favorable or most vulnerable site for the injury of the iris? Answer will be your root of the iris because it is thinnest part of the iris, right? So write down, this is the most common site for traumatic detachment, and the term for traumatic detachment of the iris is called as iridodialysis. Important question. Iridodialysis. Dialysis means detachment. So this is called as traumatic detachment of the iris. Traumatic detachment of the iris. And if they ask you which is the most common favorable site for detachment, then answer will be your root of the iris. Answer will be root of the iris. Clear? Now suppose this is your pupil and these are the group of the set of the muscles, sphincter pupillae and the dilator pupillae, right? Now they will ask you another term which is called as collarettes. Write down. Collarettes. What are collarettes? Is called as collarettes. Thickest part of iris are called as collarettes. Here, what is the location of collarettes? Reason and your ciliary body. So these are the thickest part of the iris, which are the collarettes. You have to remember the name and why they are important, because they are the thickest part of the iris. Clear? Understood the meiosis and mydriasis? Meiosis means small pupil. So they will be regulated by short ciliary nerve, and mydriasis means dilated pupil. So they will be regulated by long ciliary nerve. Clear? Now, another important question which they ask you about the causes or the differential diagnosis of the meiosis and mydriasis. What are the differential diagnoses of meiosis and mydriasis? So these you have to remember. They will be asked in your medicine also as well as in ophthalmology also. So here I will give you some mnemonic, and the mnemonic is, write down, mnemonic for meiosis, write down, high COPS. High COPS. Clear? So when COPS are high, the pupil will be meiossed, small pupil. Horner syndrome. That means in Horner syndrome, the pupil will be meiossed, right? For H stands for Horner syndrome. Another H stands for hemorrhage, which is pontine hemorrhage. Pontine hemorrhage. Now I stands for iridocyclitis. Cyclitis means ciliary body. Cycle means ciliary body, right? And itis means inflammation. So inflammation of iris as well as ciliary body is called as iridocyclitis, also called as anterior uveitis. We will discuss in uvea. Later on, we will discuss iridocyclitis in uveitis, right? Now, C stands for clonidine. C stands for clonidine, carbolic acid. O stands for organophosphates. O stands for organophosphates, and another O stands for opioids. Opioids. O stands for opioids, organophosphates. P stands for parasympathomimetics. Parasympathomimetic drugs. Another P stands for pilocarpine. This is important from ophthalmology point of view. Pilocarpine will cause meiosis. It will constrict the pupil, right? Third P, pilocarpine, and phenothiazine. Phenothiazine will also cause meiosis. Now, S stands for sleep and sedation. Sleep and sedation. So these are all the differential diagnoses which you have to remember for meiosis. And the mnemonic is high COPS. Mnemonic is high COPS. Now coming to mydriasis. Coming to causes or differential diagnosis of mydriasis. The mnemonic for mydriasis, write down. Mnemonic for mydriasis is big oats. Oats are healthy, right? Good for health. So big oats. Big oats is the mnemonic for mydriasis, where B stands for belladonna poisoning. B stands for belladonna poisoning. I stands for internal ophthalmoplegia. G stands for glaucoma. Glaucoma. Which glaucoma? ACG, angle closure glaucoma. So remember, in angle closure glaucoma, when we will discuss glaucoma tomorrow, I will ask you whether the pupil is dilated or constricted. So remember, in angle closure glaucoma, pupil will be dilated, right? Pupil will be dilated. Now coming to OATS. O stands for oculomotor nerve palsy. O stands for oculomotor nerve palsy. A stands for atropine. A stands for atropine. T stands for tonic pupil. And S stands for sympathomimetics. Sympathomimetics. So here you have to remember this atropine. Atropine is frequently used in ophthalmology, and remember, atropine will dilate the pupil, whereas pilocarpine will constrict the pupil. Pilocarpine will constrict the pupil and atropine will dilate the pupil. In open angle glaucoma, pupil will be normal sized. Normal size, normal reaction, and the size of the pupil will be normal in open angle glaucoma. Whereas in angle closure glaucoma, pupil will be dilated. So these are the differential diagnoses of mydriasis. Two mnemonics you have to remember. For meiosis, the mnemonic is high COPS, whereas for mydriasis, mnemonic is big oats. Clear? So this we have discussed iris. Now coming to second part of the uvea, After iris comes your which part? In the chat box. After iris, which part of uvea we will discuss now? In the chat box, give me an answer. Iris is the most anterior part. Then comes your CB is ciliary body, right? So we will discuss ciliary body in detail. Write down next heading. Ciliary body. Now this ciliary body, write down the functions of ciliary body. So this has a very important function. It plays role in secretion of aqueous humor. It plays role in secretion of aqueous humor, right? Now they will ask you what is the exact site of secretion of aqueous humor in the ciliary body. Then the answer will be that it is secreted by non-pigmented epithelium. Non-pigmented epithelium of ciliary processes. It is secreted by non-pigmented. So you have to remember this one. Important for your exam point of view. They will ask you the epithelium of the ciliary body by which aqueous humor is secreted. Then answer will be non-pigmented epithelium of ciliary processes. Clear? Second function, write down. So first important function of ciliary body is secretion of aqueous humor. After secretion of aqueous humor, second important function is accommodation. It plays important role. Ciliary body plays important role in accommodation of the eyes. Now, what is accommodation? Write down. Now, suppose if you want to focus on the near object, I want to focus on the near objects, on the tip of the pen, I want to focus, then what will happen? My eyes will try to converge the eyeball in order to focus on near object. That phenomenon of increase in converging power of my eyes in order to focus on near object, that phenomenon is called as accommodation. Write down the phenomenon. What is accommodation? It is a phenomenon of increase in converging power. It is a phenomenon of increase in converging power of eyes. In order to focus on near objects. So here the key point is near object, because accommodation comes into action only and only for near objects only. Right? It doesn't come into action when you are focusing on far objects. It plays role only and only when you are focusing on a near object. So here the key point is near object. Accommodation takes place only on near objects. That means only for near vision. It comes into action only for near vision. Clear? Now, what are the changes which take place when there is accommodation taking place? Image. See the image again. See, can you see this diagram? This is a magnified view of the anterior segment of your eye. This is your cornea and this is the back of the cornea, right? This is your anterior chamber, AC behind the cornea and in front of iris, right? This is your iris and these extensions, can you see? These are the ciliary processes. So this is the exact location of secretion of aqueous humor, right? So from this location, your aqueous humor is secreted. Clear? Now, can you tell me what is this part, this cross part behind the iris and in front of lens there is a potential space. This part is called as, answer in the chat box, PC, right? So this is posterior chamber. Which liquid it contains? It contains aqueous humor. Clear? So AC as well as PC, posterior chamber, both contains which liquid? Aqueous humor, right? Now this lens is your biconvex lens. This is our biconvex lens. Okay. Can you see these threads are there? These black threads are called. Can you see these black threads? So these black threads are called as suspensory ligaments. They are called as suspensory ligaments, also called as zonules, right? They are called as zonules. So these zonules, they are thread-like structures which keep the biconvex lens in its normal anatomical position. Means they are holding the lens in its normal anatomical position. Clear? So if these zonules got damaged due to any trauma, what will happen? The lens will dislocate from its normal anatomical position. Understood about zonules? Understood about zonules? Yes or no? In the chat box. So these zonules are coming from which structure? They are coming from your ciliary body, right? Ciliary body. Okay. Clear? So what will happen? What are the changes we will see during accommodation? This is the main concern here. So this is our normal biconvex lens, right? So lens is this biconvex in shape. This is the anterior curvature. Just understand, okay? Don't write anything. I'll give you the notes. This is the anterior curvature of the lens and this is the posterior curvature of the lens, right? The point where anterior capsule and the posterior capsule of the lens, PC means posterior capsule, AC here is anterior capsule of the lens. So lens has two capsules, anterior capsule and the posterior capsule. The point where the anterior capsule and the posterior capsule joins, this point of the lens is called as equator of the lens. This is called as equator of the lens. The line joining the equator of the lens, this will give you which diameter of lens? This is called as equatorial diameter. Equatorial diameter, right? Understood? So the line joining the two equator of the lens is called it will give you which diameter? Equatorial diameter of the lens, right? And these 2 points, the center point of the anterior capsule and the center point of the posterior capsule, if you join this diameter is called as, antero-posterior diameter. Antero-posterior diameter. Clear? Now write down the changes we will discuss in accommodation. Write down heading, changes during. So what are the changes which are going inside the eyeball when you are trying to focus on near objects? Remember, accommodation is only for near objects, right? So write down. First, whenever there is accommodation, need for accommodation, your ciliary muscles. What was the function of accommodation? Accommodation was played by which part? Ciliary body, right? Ciliary body contains ciliary muscles. Clear? So whenever there is accommodation, ciliary muscles will, obviously they will contract. Clear? Now whenever, remember, ciliary muscles contract, what will happen? These zones, they will relax. Okay. So whenever I am focusing on near objects, my zonules will be in tense. They will be in tense state, right? And whenever I am focusing on near objects, my zonules will relax. My zonules will relax. So when zonules relax, because zonules are in contact with my lens, right? So what will be the changes in the lens? My anterior capsule or my anterior curvature of the lens, write down, anterior curvature of the lens, it will increase. Anterior curvature of the lens will increase. Remember, next important point, whenever the curvature of any structure inside the eye, be it cornea or be it lens, whenever the curvature of the lens or cornea increases, the power of that structure will automatically increase. So power of the lens will also increase. Can you tell me the power of cornea? We have discussed this. What is the power of cornea, refractive power of cornea we have discussed? Total power of eyeball was 60 diopter, right? What is the power of lens? What is the power of cornea? Answer in the chat box. Refractive power of cornea. No answers? We have discussed this. Am I audible? Am I audible now? Okay. 43 diopters, right? So total power of the eye is 60 diopters, out of which cornea constitutes 43 diopters. So I was telling you, whenever the curvature of any structure of the eye, be it cornea or lens, power of that structure will increase. Clear? So this is the second important change which will happen during accommodation. First was ciliary muscles will contract. Automatically, the zonules will relax and the anterior curvature of the lens will increase. Fourth change, write down. The posterior curvature of the lens, there will be no change. So there will be no change in the posterior curvature of the lens. Clear? Fifth change, write down. The anti-diameter. Obviously, suppose this is the lens in normal state, this is your normal state lens. Whenever there is accommodation, what will happen? The anterior curvature of the lens will increase, whereas there is no change in the posterior curvature of the lens. So what will happen to the AP diameter? Obviously, the anterior posterior diameter of the lens will automatically increase. AP diameter of lens will increase. Okay. So these are the 5 changes which take place during accommodation. And accommodation, remember, it comes into action only and only for near vision and not for far vision. This much is clear? Yes or no? Accommodation is clear? Yes or no in the chat box? Great. So this is the power, natural power in our ciliary body to focus on the near objects. Okay. Now, whenever we are aging, right? Whenever we age, suppose I am 30 years old, whenever I age and I reach 40. When I reach 40, so what happens? The normal converging power of our ciliary body and our lens, it automatically decreases, right? It automatically decreases. So our ability to focus on near objects will decrease whenever we are approaching towards 40 years, right? So that insufficiency of accommodation is called as presbyopia. That is called as presbyopia. Write down. What is presbyopia? It is physiological insufficiency. Physiological insufficiency of accommodation. It is physiological insufficiency of accommodation. So can you tell me what type of loss of vision will be there in accommodation? There will be loss of, at the age of 40, there will be loss of near vision, obviously, because accommodation takes place for near vision also only. So loss of near vision will take place. It occurs around which age? Around 40 years of age. So whenever you reach 40, there will be a physiological insufficiency for accommodation. Patient will get difficulty to focus on near objects. Means in order to, if patient wants to read newspaper, patient will not be able to read the newspaper. Patient will have difficulty. That physiological insufficiency is called as presbyopia. What is the treatment for presbyopia? We will prescribe convex glasses. Convex spherical spectacles are prescribed to the patient. Okay, so convex spectacles are prescribed. Remember, these convex lenses are plus lenses and concave are minus lenses. Concave are minus. Concave are minus, convex is plus. So in presbyopia, which type of lenses we give? Plus glasses are we give. Convex spherical spectacles we prescribe to the patient in presbyopia. Clear? This much is done. Shall we move now to the next topic? Give me a thumbs up in chat box if you are done. Okay, good. So next topic we will take on, next important structure is your retina. Next important structure is your retina. As I told you, this is the normal retina, right? So whenever you are doing internship or you are doing your residency, you must have got some fundus calls, right? Fundus calls are advised by medicine and by gynae department. So they want to, what do you mean by fundus? They want your retina examination to be done, right? So this is the normal retina, how it looks. This is a picture of your normal retina, right? This is the normal retina. Can you see this? Appreciate this circle, this part. This part is called as your optic nerve head. This part. This circle is called as your optic nerve head. Okay. Can you see this depression in the center, the black circle? Can you see appreciate depression? This central depression is called as your macula lutea. This is called as macula lutea. Yeah, for accommodation, if you want to correct accommodation of presbyopia, then only and only convex lens is given. Only plus glasses are given in presbyopia, never the minus lenses. Yes, I'll share you some written PDF notes after the class. I'll share you the images also. All the images will be shared as well as some written notes also I'll share with you, right? Okay. So this is a normal picture of your retina examination. This structure is your optic disc, also called as optic nerve head. Optic disc or optic nerve head. And this central depression in the black circle is called as your macula lutea. This is called as macula lutea, right? Write down. Next heading, write down. Retina. Next heading, write down. Retina. This retina is, remember, this is the innermost neural layer. With the help of optic, it contains parts like optic disc. First part is called as optic disc. Also draw the diagram here. This round part is called as optic disc. From the optic disc, vessels are emerging. From the optic disc, certain vessels are emerging. And there is a central depression, like this yellow depression is there. This is called as your Macular Lutea. And this part is called as your optic disc. Also known as, optic disc is also known as optic nerve head. This is called as optic nerve head. Now try to understand. Suppose this is my eyeball. From the eyeball, from the posterior aspect of the eyeball, this is eyeball. From the posterior side of the eyeball, suppose this is my optic nerve, right? This is my optic nerve. This optic nerve is normally 47 to 50 millimeter long, right? Now, as an ophthalmologist or as an eye surgeon, if I want to examine the fundus of the retina of the patient, I can only see the head of this optic nerve inside the eye. I can only see the head, this part. I can only see the head of the optic nerve, which is also called as optic disc. I cannot visualize the whole of the optic nerve. Okay. Being an ophthalmologist, I can only examine, I can only visualize the condition of the head of the optic nerve, which is called as optic nerve head. Okay. Rest of the optic nerve is going into the brain. Rest is going to the brain, and I cannot visualize the rest of the optic nerve, right? So this head of the optic nerve, you have to remember, as in ophthalmology, this head of the optic nerve is called as optic disc, right? This optic disc is important for your glaucoma also. We will discuss why in glaucoma section. So this is clear about optic disc. What is optic disc? Give me a thumbs up if you have any problem or if I need to repeat. Optic disc or optic nerve head is clear in retina. Okay. Okay, now write down. This optic disc, write down. First heading is optic disc in retina. We will discuss optic disc in detail. This optic disc is, write down, this is first intraocular part. This is the first intraocular part of optic nerve. Understood? So this is the first intraocular, and we are discussing intraocular only. So this first intraocular part of optic nerve is also known as optic nerve head. ONH is optic nerve head, right? Now, what is the normal color of this optic nerve head or optic disc? It is pale pink in color. It is pale pink in color. What is the normal shape? Normal shape of optic disc. Always remember, it is always and always, normally it is vertically oval in shape. It is vertically oval in shape. Length of optic nerve is not important for your exam point of view, but if you want to know, the normal length of optic nerve is 47 to 50 millimeter long. 47 to 50 millimeter long optic nerve. Clear? So you have to remember the color, the shape. It is vertically oval, not horizontally oval. It is vertically oval in shape. If they ask you the diameter of optic nerve head, also you have to remember it is 1.5 millimeter. It is 1.5 millimeter. Again, I am drawing the diagram. Suppose this is our optic disc. The diameter, the vertical diameter is 1.5 millimeter, right? This is the central depression, which is called as Macular Lutea. Understood? Now, in the center of the optic, disc, you will see a yellow depression is there. The central depression is there. This central depression or round structure, yellowish depression, is called as optic cup. It is called as optic cup. And as a whole, this is called as optic disc. Okay. Now, this normal optic cup to disc ratio, if you see the whole cup, if you see as the whole optic disc or optic nerve head, optic disc as this round structure, the central yellow depression is called as optic cup. Now, if you take the fraction of this cup to disc ratio, normal cup to disc ratio, if you consider this disc as 1, then cup is 0.3. The normal cup disc ratio is 0.3 or less than 0.3, right? So if they ask you normal cup disc ratio, answer will be 0.3 or less than 0.3 is the normal cup disc ratio. In short form, we call it as CD ratio. CD is cup to disc ratio. So normal cup to disc ratio is 0.3 or less than 0.3. This much is clear? Give me a thumbs up. Should I repeat? Clear? Shall we move on now? Clear. Okay, good. So this was about your optic disc, right? Next, write down in optic cup only. Write down. Next is optic cup. What is the location of optic cup? Write down. This is a central depression. Optic cup is a central depression through which central retinal artery, central retinal vessels, artery and veins emerge. Can you see in the diagram also? I have drawn the diagram. In this previous diagram, the vessels are emerging from the optic cup, right? So this is a central depression through which central retinal vessels, they emerge. Okay. Now OD is optic disc, right? OD is also known as physiological blind spot of Marriott. Physiological blind spot of Marriott. Important question. If they ask you which is the blind spot of Marriott, physiological blind spot of Marriott, answer will be optic disc. Optic disc. Clear? Now, what do you mean by blind spot? Just try to understand this concept also. See, we are studying retina, right? So whole of the retina takes part in visual formation, visual pathway, right? Except one physiological part, that is called as your optic disc, right? So in optic disc, what is the importance of optic disc? This optic disc does not contain any photoreceptors, right? What are the normal photoreceptors? You know, rods and cones, right? So these rods and cones are absent normally in normal patients, normal individuals. These rods and cones are absent at optic disc. So that is why there is no visual formation at the optic disc. That is why this optic disc is called as blind spot. Okay, because it does not take part in visual formation or vision, right? So that is why it is called as blind spot of Marriott, and that is normal, right? It is present in me also. I have also blind spot at the optic disc, and you also have. So that is a physiological process. It is normal. Understood? Yes or no? Give me a thumbs up if it is clear. Concept of blind spot. Normal physiological blind spot in eye is optic disc. It does not contain any photoreceptors. That is why there is no image formation at the optic disc and you get a blind spot. What is blind spot? Blind spot is a non-seeing area. Blind spot is a non-seeing area which is surrounded by seeing area, which is surrounded by a seeing area. So this black dot which is not taking part in visual formation is called as blind spot. Understood? If rods and cones present means it is pathology, are you saying? See, in whole of the retina, rods and cones are present, right? Rods are present in the periphery of the retina, cones are more present in the center, in the macular lutea, right? Blind spot is also there in individuals who have specs. Yes, blind spot is normal. See, every individual has optic disc, right? This optic disc is present in all of us in our retina, and optic disc is a blind spot because there are no rods and cones. That is why there is no image formation in our optic disc. Okay, so we all have this blind spot which is normal. Okay, understood? Clear? Optic disc is the optic nerve head. It does not take part in image formation. That is why it is called as blind spot of Marriott. It does not have any rods and cones. Okay. Right. So as we have discussed, the normal cup disc ratio, CD ratio is less than equal to 0.3. Right. Now again, try to understand the concept. Right. This is our optic disc, and this is our central depression, which we have discussed. It is called as optic cup. Right. So this is our cup, and this is our optic disc. Right. Normal cup disc ratio is 0.3, less than 0.3. Now, can you see in this inferior quadrant, this part, this gap? This gap is called as NRR. The distance between the optic cup and the optic disc margin, this gap between the optic cup and the disc margin is called as NRR, which is called as neuroretinal rim. This part is called as, this gap is called as neuroretinal rim. Write down NRR. Okay. This is called as neuroretinal rim. Now, why this neuroretinal rim is important? Write down. In healthy eyes or in normal eyes, inferior NRR or neuroretinal rim is thickest or broadest. As compared to other quadrants or as compared to other sectors, the inferior NRR is broadest in normal individual, in healthy eyes. And it follows a rule which is called as Isnt rule. It follows a rule which is called as Isnt rule or Isnt rule. That is important for your exam. Isnt rule means that inferior NRR is broadest, followed by superior, followed by nasal, and then temporal, So inferior one is the broadest in healthy individuals. Clear what is NRR and what is Isnt rule? Any doubt? Should I repeat? Give me a thumbs up if it is clear. Give me a thumbs up. Repeat. Okay. Again, I'll draw the diagram. This is our optic disc. Okay. Okay, I'm repeating. This is our optic disc. This much is clear, right? Optic disc is also called as optic nerve head, right? Tip of the optic nerve head. Clear? This was tip, right? So this is our optic disc, and this central depression is called as optic cup. This is called as optic cup, right? So the gap between the optic cup, this gap between the optic cup and your disc margin, this gap is called as neuroretinal rim. NRR. Okay. And this thickness of the neuroretinal rim is not uniform in all the four quadrants. It varies. The thickness varies, right? Now, what is the variation? In healthy individuals, it follows the rule which is called as ISNT rule, which states that the inferior rim, the inferior, this inferior rim, this inferior neuroretinal rim is the broadest. It is the broadest rim or the broadest sector as compared to superior, followed by nasal, and followed by temporal. Means the temporal rim is the thinnest one. N and T stands for N for nasal, T stands for temporal. Temporal NRR. See, this is inferior, this is temporal, this is superior. This is superior NRR and this is nasal NRR. So that means inferior rim is the broadest one. Then comes your superior rim, thickness wise, and then nasal and then temporal. So temporal rim is the thinnest one and inferior rim is thickest one in the normal individuals. Clear? Isnt rule is clear? Isnt rule means inferior NRR is broadest, then comes your superior rim, then nasal, and then temporal rim. Give me a thumbs up now if it is clear. Good. So Isnt rule is followed in healthy eyes, right? Now we have seen the picture. Coming back to the retina examination, this picture, this is a normal fundus picture. And can you see this black depression inside the black outline? This depression is called as Macular Lutea. Write down. This is called as Macular Lutea and it is a yellow spot. Write down. This is a yellow spot. Lutea means yellow. Lutea means that it is yellow in color. Lutea means that it is yellow in color. Now in the exam, they ask you why it is yellow in color because of the xanthophyll pigment. Important, lutea is yellow in color because of which pigment? Because of which pigment? Xanthophyll pigment. This pigment name you have to remember in macular lutea. Clear? Now coming back to next question, write down. In macular lutea, what is the location of macular lutea? Write down. It is situated, macular lutea is situated 3 millimeter temporal to optic disc and slightly inferior to it. And slightly inferior to it means, suppose this again the diagram, this is optic disc, this is optic cup, vessels are emerging like this. This is our macular lutea somewhere here, right? Now, what is the location of macular lutea? It lies 3 millimeter. This is 3 millimeter temporal to the optic disc and slightly inferior to it. Slightly inferior to the level of the optic disc. Okay. So it is situated 3 millimeter temporal to the optic disc and slightly inferior to it. Next important question, write down. In the macular lutea itself, macular lutea contains certain pigments which are called as carotenoids. It contains carotenoids. It contains lutein. It contains zeaxanthin. These three pigments, carotenoids, lutein, and zeaxanthin, they act as antioxidants. So natural antioxidants are present in the macular lutea, and the name of these antioxidants you have to remember because they are very, very important for your exam. Carotenoids, lutein, and zeaxanthin are the antioxidants which are present in the macula lutea. Clear? Now, if they ask you the diameter of this macula lutea, can you see this diameter? Write down the diameter of macula lutea. Diameter of macula lutea is 5.5 millimeter. Diameter of macula lutea is 5.5 millimeters. Okay. Now again, I'll repeat. If they ask you what is the normal vertical diameter of optic disc, answer will be 1.5 millimeter. Okay. Its normal shape is vertically oval and it is pale pink in color. Now, if they ask you what is the normal location of macula lutea is always and always, it is always temporal to the optic disc. It is not nasal to the optic disc, not superior, not inferior. It is always temporal to the optic disc. And how much temporal? 3 millimeter. It is 3 millimeter temporal to the optic disc and slightly inferior to it. Right? Slightly inferior to the optic disc. And what is the diameter of a macula lutea? It is 5 millimeter, 5.5 millimeter. Now, if someone is asking, is that a left eye? Now, how will you see whether it is left eye or right eye when you are examining the fundus? Now, suppose I am seeing this fundus. If the optic disc is in your left side, then it is your left eye. If the optic disc is in your right side, then it is your right eye. Understood the concept? If you are seeing the optic disc in your right side, then eye will be right eye. And if it is in the left side optic disc, then it is left eye. Give me a thumbs up if it is clear. Concept is clear. How can you identify which eye it is? With the help of optic disc. Yeah. Okay. Now, what is the location of fovea centralis? Now, if you see the center point of the macula lutea, this center point of the macula lutea, this point is called as fovea centralis. As the name suggests, it's centralis. Centralis means center. So this fovea centralis is located in the center of the macula lutea. Simple. Okay. Now write down. Next important point after macula lutea, write down fovea. Fovea. Important question, write down. This is the most sensitive part of retina. Now, in layman term, if someone asks you which is the most sensitive part of the eye, then answer will be your retina, right? If they ask you which is the most sensitive part of retina, then answer will be your fovea centralis. Okay. Now, why it is most sensitive part of retina? Write down. Next important question. Because highest visual acuity is present at fovea centralis. Highest vision is present at the fovea centralis. Why highest visual acuity is present at the fovea centralis? Because next important point about fovea centralis, only cones are present at fovea centralis. Rods are absent. Rods are absent. So fovea centralis, what is the location of fovea centralis? Suppose this is our macula lutea. Okay. And this is the center point of the macula lutea. So this center point of the macula lutea is called as fovea centralis. This is the most sensitive part of your eye because in the fovea centralis, highest visual acuity is present. Next, only cones are present, rods are absent. Now, what is the location of rods then? If you see the retina, this rods are present in the periphery of the retina, this cross. Rods are present in the periphery of the retina in more number, right? whereas cones are present in the center of the retina, in the macula. Understood? That is why rods are responsible for your peripheral vision. Peripheral vision. If I have to see in the periphery, my rods will be functioning. Okay, if I have to see in the center, so central vision is regulated by your cones. Okay, clear? Fovea centralis is clear. Highest visual acuity, only cones are present as a fovea centralis. Rods are absent. What is the location of rods? Rods are present in the periphery of the retina. Cones are present more in the center of the retina, means at the macular lutea. Give me a thumbs up if it is clear, or should I repeat? Location of optic disc is posterior, then how left side in left eye? Location of optic disc is posterior. Yeah, see, this is a globe and this is your optic nerve, and you can only visualize through the retina examination. You can only visualize the optic nerve head, optic disc, right? So when you visualize the optic disc will not be never in the center. Either it is present in the left side or in the right side in the retina examination, right? So if it is present in the left side, then it is the left eye. And if it is in the right side, then it is the right eye. Okay. So fovea centralis is clear. Only cones are present in the fovea centralis, and it contains highest visual acuity. And third important question is that it is the most sensitive part of retina. If by any chance or by any disease, your fovea centralis gets damaged, then the patient will become blind. Then there will be highest loss of the vision and the patient will become blind. Okay? Clear? Now write down. Next, write down layers of retina. Next heading, write down layers of retina. So this was all about your retina, of retina. How many layers of retina are there? Any idea how many layers are there? Cornea were there. There were 6 layers in the cornea. Whereas in retina, if you there are the 10 layers are there in the retina. 10 layers. No. 9 in retina. No. 10 layers are there in the retina. Depends. It's not, you can say that it is permanent loss of vision, but it will be definitely the highest loss of vision. Maximum loss of vision will be there if your fovea centralis is gone, because it is responsible for maximum vision. In many diseases, it can be permanent also, but if it can be curable also. So you can't predict in general that it is permanent loss of vision. Okay. But if it is there any disease like diabetic retinopathy and your fovea is involving, then there will be maximum loss of vision because of involved macular lutea. Right? So there are, I told you there are 10 layers of the retina over there. Okay. No 9 layers, 10 layers of retina are there, right? So no need to remember all the names of the layers of the retina. Just remember the outermost and the innermost of the retina. Okay. Now try to see. Suppose these are the 10 layers of the retina. These are the 10 layers of the retina. Okay. 10 layers are there. Now, if you talk about this one, this is suppose the outermost layer of the retina. This one. This is the outermost layer of the retina. This outermost layer of the retina, the name is called as RPE, retinal pigment epithelium. Outermost layer of the retina, the name is retinal pigment epithelium. Okay. And this is the innermost layer of the retina. The name is internal limiting membrane. As the name suggests, internal means innermost, right? So this is the innermost layer, internal limiting membrane, and this is the RPE. Outermost layer is retinal pigment epithelium. Okay. Now, can you tell me which layer of the eyeball is present behind or beneath this RPE? Which layer of the eyeball is present? Which layer of the eyeball is present beneath this RPE? Which layer is present? Choroid. As I told you, the middle layer is choroid, right? So choroid, after choroid comes your retina. So retina is in direct contact with your choroid, right? So this RPE is in direct contact with the choroid. Beneath the RPE is choroid. This is RPE, this is your internal limiting membrane. And these are the other 10 layers of the retina. Okay. Now, the concept which you have to understand is that there is a potential space between the outermost layer and the rest of the 9 layers of the retina. Suppose these are the rest 9 layers and this is the outermost layer. There is a potential gap between these 9 layers and your outermost layer. And this potential gap is called as subretinal space. That space is called as subretinal space. Understood? What is the location of the subretinal space? This space is present between RPE and the rest of the 9 layers of the retina. Understood? So whenever, and you see these potential space, subretinal space is present between the RPE and the 9 layers of retina. These 9 layers of the retina are called as, these 9 layers of retina are neurosensory retina. They are called as neurosensory retina. So as I told you, there is a space, potential space in normal individual between the RPE and the 9 layers of the retina. Innermost layer is internal limiting membrane. Internal limiting membrane, right? As I was discussing, subretinal space is present between the RPE and the rest of the 9 layers of the retina. That is why there are high chances that due to any disease or any detachment, these RPE and the 9 layers of retina get detached with each other. So these 9 layers can get detached with the RPE, which is the outermost layer. That condition is called as retinal detachment. Okay. Now write down. Write down in the layers of retina. The layers of retina are divided into 2 parts, the neurosensory retina and the RPE. RPE is the outermost layer, which is having the metabolic functions. RPE is the outermost layer and it is having metabolic functions. Like which layer of cornea? Which layer of cornea was having metabolic functions? Can you tell me? Answer in the chat box, please. Fast. Which layer of cornea was having metabolic functions? Endothelium. Correct. So similar to endothelium, here in retina, which layer is having metabolic functions? RPE. RPE is the outermost layer which is having metabolic functions. And rest of the 9 layers of retina, we divide it as neurosensory retina. 9 layers of retina are called as neurosensory retina. And there is a space. Write down this important point, important question. The space between neurosensory retina and the 9 layers, space between neurosensory retina and 9 layers is called as subretinal space. Subretinal space. Clear? So this is the diagram. This is the outermost layer which is called as pigment epithelium. Behind the pigment epithelium, choroid is present, right? So somewhere here is the subretinal space between the rest of the 9 layers and your RPE. Clear? Understood this one? Concept is clear of subretinal space. What is subretinal space? What is the location of subretinal space? What is neurosensory retina? The 9 layers of retina is called as neurosensory retina. Outermost layer is called as RPE, retinal pigment epithelium, which is having metabolic functions. Clear or not clear? Clinical significance of subretinal space we will discuss in retina. Just remember that it is a weak point. It is a weak connection between RPE and the neurosensory retina. Okay? Because of this space, the strength is weakened. So there are high chances, because of any pathology, that these 9 layers can get detached from the RPE because of this subretinal space. Okay? What are those pathologies we will discuss in retina? Any other queries? Any other questions? Clear? So these were the 9 layers of retina. No need to remember all the names. Okay, just remember these points. Now coming back to important questions, write down in the write down. Question number 1. Question number 1, very frequently asked. There is no concept. Just remember the mnemonic for this. Okay. They will ask you which is the first order neuron. First order neuron. Second order neuron. Third order neuron. Third order neuron. LGB. As lateral geniculate body, right? Lateral geniculate body. So if you want to get the order of the neuron, just reverse this order. So first order for answer is bipolar cell. Second order neuron, G for, write down. Second order neuron, G for ganglion cells. G for ganglion cells. L for again lateral geniculate body. Lateral geniculate body. LGB you have to remember, and you have to just reverse the order. And you will get the correct order of neurons. Okay? LGB is clear or not? First order, second order? Give me a thumbs up. LGB, and you have to reverse the order. B for bipolar, G for ganglion cells, L for lateral geniculate body. First order neurons, second and third order neurons. Clear? Okay. If they ask you, write down question. Which is the first site of action potential generation? First site of action potential generation, then answer will be ganglion cells. Answer will be ganglion cells. Important. Answer will be ganglion cells. Clear? Answer will be ganglion cells. Now coming back to diagram. This picture of the eyeball, which I showed you in the beginning of the class. Let us revise again. So as I told you, AC and PC contains which liquid? AC and PC contains aqueous humor, right? Okay. AC and PC contains aqueous humor. So this is the innermost layer of the retina. This innermost layer of eyeball is called as. Break I'll take in 10 minutes. 7 o'clock I'll take a break. Okay. So innermost layer of the retina is called as. Innermost layer is called as this. This one is retina, right? Okay. This is retina. So as I told you, this one is AC. And this one somewhere here is the PC, posterior chamber, right? Now there are chambers we have discussed about the segments. How many segments are there? There are 2 segments in the ophthalmology, anterior segment and posterior segment. Now they will ask you what is the location of and what are the structures which are present in the anterior segment of the eyeball, right? So now listen to carefully and see in the picture. All these structures which are present in front of the posterior capsule or the posterior capsule of the lens. This is posterior capsule. This is posterior capsule, right? This was anterior capsule. This is posterior capsule. So all the structures which are anterior to this posterior capsule of the lens, they comprises your anterior segment of the eyeball. They comprises anterior segment of the eyeball. That means anterior chamber, posterior chamber, as well as your lens, they comes in anterior segment of the eyeball. This much is clear or not? Give me a thumbs up. Anterior segment means all the structures which are anterior to the posterior capsule of the lens. There were 2 capsules in the lens, anterior capsule, posterior capsule. This was our natural lens is biconvex, right? So this is anterior capsule and this is posterior capsule. All the structures which are lying anterior to the posterior capsule of the lens, they comprises your anterior segment of the eyeball, right? Now, what is posterior segment of the eyeball? All the structures which are lying posterior to the posterior capsule of the lens, they comprises your posterior. They comprises posterior segment of the eyeball. This much is clear? Anterior segment, posterior segment clear? Give me a thumbs up. Give me a thumbs up. Now my next question to you is, which liquid is present in the posterior segment of the eyeball? Which liquid is present in the posterior segment of the eyeball? As it is seen in the picture also, it is the vitreous humor. So posterior segment is filled with the vitreous humor. And which is the liquid which is present in anterior segment of the eyeball? Aqueous humor. Aqueous humor. Clear? Understood? Right. Now, last important point in the retina, write down. Understand this. This is your retina, right? Innermost layer. This one. So this is the innermost layer, which is the retina. It starts from this side and it goes like this. Somewhere here is your macular lutea and somewhere here is your optic nerve, this part. And this is whole of your retina, right? So this junction of the ciliary body and your retina, this junction, can you see this junction? Blue part, this junction of your ciliary body and the point where the ciliary body ends and your retina starts. The point where your ciliary body ends and your retina starts. Can you appreciate this point? Can you appreciate this point? This point is called as ora serrata. This point is called as ora serrata. Now, write few points about ora serrata. You understood the location of ora serrata? Of retina. It is the anterior termination of retina is called as ora serrata. Clear? Why it is anterior? Because we are going towards anterior segment. Na? We are going towards anterior segment. So this is the anterior termination point of the retina, junction of ciliary body and retina. This point is called as ora serrata. Okay. Now, few important questions. Ora serrata. It is the anterior. It is anterior termination of retina. Anterior termination of retina, and it is the junction of ciliary body and choroid. Write down important question. What is the anatomical significance of this structure? Anatomical significance of ora serrata. Write down to determine. It helps to determine the site. It helps to determine the site of intravitreal injections. Intravitreal injections and the point of penetration of the needle. Needle is always ora serrata. Point of penetration is always anterior to ora serrata. Right? Now suppose this is our globe, right? Now in certain pathologies like diabetic retinopathy, hypertensive retinopathy, and some dreadful infections, we have to give antibiotic injections or anti-VEGF injections directly into the posterior segment of the eyeball in the vitreous cavity, right? Now suppose this is our injection, right? So what is the location of the injections, right? So this ora serrata helps to determine the site of injection. This point penetration of the needle has to be always and always anterior to the ora serrata and never posterior to ora serrata. Why? Why never posterior to ora serrata? Because if you penetrate the needle posterior to ora serrata, you can hit the retina. Because posterior to ora serrata, which structure is lying? Retina, right? So if the point of penetration of the needle is posterior to ora serrata, you can damage retina. So that is why the point of penetration of the needle in intravitreal injections is always and always it is anterior to ora serrata. Understood? Okay. This much is clear. Point of penetration of the needle in every injection. Whatever injection we are giving in the posterior segment of the eyeball in the vitreous cavity, the needle will be anterior to ora serrata and never posterior to ora serrata. Give me a thumbs up if it is clear. Should I repeat? Clear. Injection will not be given in the aqueous cavity because these are severe infections and the effect has to be seen in the posterior segment because these are the pathologies of posterior segment. Changes are present in the retina. So directly you will give antibiotics in the retina, in the vitreous cavity. So they will not enter in the aqueous cavity. Why? Because there is lens. Lens is present, iris is present, they will block the entry. So the injection will be limited to the posterior segment only. Now next point write down. Next heading write down, embryology. Some important questions which are frequently asked from your embryology part, write down. Structures which are derived from surface ectoderm. Structures which are derived from surface ectoderm, write down. First write down, it is the epithelium of conjunctiva. epithelium of conjunctiva, epithelium of cornea, lens. Lens is ectodermal in origin. And fifth is lacrimal glands. Lacrimal glands. These are the structures which are derived from surface ectoderm. Talking about mesodermal structures, mesoderm. Talking about mesoderm, the extraocular muscles, all are mesodermal in origin. Extraocular muscles are mesodermal in origin. Neuroectodermal structures, neuroectoderm. Neuroectoderm. First is optic nerve. ON is optic nerve. Second is retina. Retina. Then which are the two muscles? Sphincter pupillae and dilator pupillae. These are neuroectodermal in origin. Last, neural crest cell derivative. Neural crest cells derivative structures. Answer is ciliary muscles. Neural crest cell derivative structures are ciliary muscles, sclera, and trabecular meshwork. Trabecular meshwork. Clear? Surface ectoderm. 5 structures are there. So first is epithelium. Surface ectoderm, I'll repeat. Epithelium of conjunctiva, epithelium of cornea, lens, and lacrimal glands. Lens and lacrimal glands. 4 structures. 4 structures are there total. Neural crest cell derivative. Trabecular meshwork is important. Out of these, trabecular meshwork is important. Optic nerve head is important. Retina is important. Iris is important. Question has been asked on trabecular meshwork also. It is neural crest cell derivative. Clear? So we'll take a 10 minutes break and then we'll start with next chapter. Okay?